Hello again. How would you describe the NHS? And I don't mean it's a national health service, but actually structurally, organisationally. How do we have a model that describes it? Now, of course, it depends why you're trying to describe it. One of the things I'm involved in is the project assessment group for the successor to QMAS. This is the programme that calculates payments for the QOF and will actually calculate quite a lot more in the future. Now, its model of describing so far has been to put providers, contractors and possibly a manager in the middle. Now, that's certainly a very effective model there. Now, when I'm looking at running the QOF database website, I've got a different model. I've got a very hierarchical model. And actually in the new NHS, that's changing. So I'm having to look at the model again. Practices are members of PCTs or health boards. But actually increasingly they're going to be members of commissioning groups as well. In fact, probably for next year, they may be members of both in a kind of parallel hierarchy. So that's certainly another way of doing it. But how do we describe the IT systems, the IT hierarchy of the NHS? Who exactly is a provider and who exactly is a customer? Now, on the pages of EHI, we're seeing lots of descriptions in hospital systems of the people that write the programme, the hospital, and the difficult contractual relationship going through another organisation. But that very much came home to us a couple of weeks ago when our EMA system went down for several hours during the day. Now, I had the sense to be sitting beside a swimming pool in a different country at the time, but for my colleagues who had less precognizance of this, it was a very difficult time. It's very difficult to try and explain to patients that, no, we don't know what tablets you're having, we don't know what your test results said, we don't know what the hospital said, and I can't honestly tell you when your appointment is. There is no effective backup system. Reversion to paper is an input-only option. The problem we found was in the aftermath. We suffered real losses. We have staff staying extra just to rekey information in. We had more appointments to provide because of the fairly useless appointments we were able to give at the time. We can give emergency care, but the chronic care went by the by to a large degree. But what exactly was our relationship with EMIS? We didn't appear to be the customer. We couldn't see an uptime. There certainly wasn't any compensation or anything in our contract. In fact, as far as we could tell, we didn't really have a contract with them at all. And it's not really a problem with EMIS, because EMIS are actually normally fairly responsive to requests from GPs. But they do seem to be torn in a difficult position between GPs and actually the people that pay the bills. 7 or 8 years ago, it was GPs that paid the bills, and it was a much clearer relationship. Now, over the next few months, we're going to see increasing numbers of providers, ex-PCTs, providing to clinical care groups. And we really must get a grip on who exactly is the customer, and who exactly is the provider, and who's the middleman. Do we really need them?